Hello, everybody, and welcome to today's ISNTD Connect meeting. I'm Marianne Comperet. I'm speaking from the International Society for Neglected Tropical Diseases, and it's my greatest pleasure to welcome you all here today for today's session. Today, we're invited and we're delighted to welcome Dr. Mark Sherlock. Hi, Mark.
Hi, good to be here.
Nice to see you too. Mark, you are health advisor at Médecins Sans Frontières. You're working, focusing particularly on Nigeria, Iraq, and Jordan. And today you've come to speak to us about a specific disease, which is Noma. We're going to hear a little bit more about the disease Noma. This is within neglected diseases, extremely neglected, and yet sadly, strikes a huge number of patients and can be fatal in 9 out of 10 individuals within days. So we thought that, Mark, as a way of introduction to today's topic, we could play a very short film, which was made in collaboration with Médecins Sans Frontières. It's based on a much longer feature called Restoring Dignity, a Journey with Noma Survivors. And this shortened version is called Surviving Noma. It's been produced by Inediz Productions and in collaboration with Médecins Sans Frontières, and perhaps we'll take this opportunity to play this by way of introduction to the disease and to some of the work that you've been doing in the field.
Ina kwance lokacin ina kamar zazzabi, yana jin na ya kumbura duka. In sa hannu na yana jin din yayi laushi. Sai nake kuka. Ina kuka ina kwance ni ne kada a zaure ko da sa hannu in ji ya tsure.
Noma is a gangrenous infection of the face, which usually starts from the gum or the gingiva to the fleshy parts of the face. It destructs the bones, the soft tissue, and everything around the face. It affects children at the age of 2 to 7 years old, but usually from 2 to 4. It can affect anywhere on the face, mainly on the sides. And there's also a central Noma which affects the nose and the upper lip or the lower lip.
No kaga da rawanin da ko da ni tashi da rawanin gani da ni wayo rawanin ga kullu irin ina tare da wannan rawani ina rufe fuska na. To sai ni hita tan wani kaya ne zabo ko Allah ya bani wallahi.
Na sai kara ko ina tare da su. Ka gani don mata na biyu yayi duk sun ka jahai. Yan kayo ni aka ce ko ni aiki la tahiya ni kai don ba mu so ne. Ce to ni mutuwa dai ka sani in tahi in bari.
Noma patients really have that stigma whenever they get into the society. It's hard for them to, integrate into the society because of the disfigurement on the face. And they also have a lot of difficulties while eating, while feeding, because if half of the face is down, is gone, is eaten by Noma, you'll find out that patients, have to do some maneuvers for them to get food into their mouth and then to swallow. And part of the problems they are facing is a speech problem.
When somebody is like that, definitely there will be intimidation between you and people.
Ni da wannan ciwon ya hana ni abu da dama. Gaskiya wannan ƙarami abu da dama tana hana da na iya shiga cikin jama'a in zauna. Kuma haka da na iya wannan. Haka kana yawo haka a cikin gari. Da sosai da.
one came to this hospital and go back remaining the same. Because the way they come, they will go back different. Since the operation was done, I'm so happy. I can go to anywhere. I can stand with people at anywhere. I felt I too am a human being like others. To anybody that is in my condition like this, they should not feel bad and they should not lose hope.
That's a really beautiful film, and a big thank you to Claire Jeantet and Fabrice Cantarini, who work with Inediz Productions, who created this film and really chart beautifully not just the story of the information about the disease, but also the story and the journey of all the patients, and that is presented in a very beautiful way. So if you can catch a showing of the whole documentary, Restoring Dignity, please do so, or get in touch with Inediz on how you might be able to arrange a screening and so forth. But underpinning this, there is a huge amount of operational research and also interventions by MSF in the field. So Mark, it'll be really wonderful to hear a bit more on that now from you. And so I'll hand over to yourself, Mark, and who will be giving us a brief presentation about MSF's work.
Yeah, I'm here in Amsterdam currently, like the rest of us, working from home in a lockdown situation. Slowly getting used to working with webinars and online conferencing, which is actually working out much better than I previously would have thought, but still not clicking on the microphone when I'm ready to talk.
Yeah.
Rookie challenge.
It's a rite of passage.
Yeah, exactly.
And you would have been out in the field at the moment. You were telling me you'd probably have taken quite a few flights by now. You've been visiting Nigeria, possibly Iraq and Jordan as well. Yeah, no,
of course, it's had a big impact on people like myself who frequently travel to the field. And all those trips have been cancelled. So we've been doing virtual field visits and other things as best as we can. But it's adaptation, and I think us and I think everybody attending this is also having to go through the same adaptations. And we're kind of find that the efficiency, I think, is getting better again as we get more used to new ways of working.
Fantastic. Okay, well, we can probably continue this discussion, and attendees, don't forget, we'll have a lovely question Q&A after Mark's presentation. So if you have any questions, please add them in our little chat feed, and we'll be talking to you shortly again. So over to Mark now. I'll launch the presentation.
That's great. Thank you very much.
Thank you.
So welcome, everybody. It's a great pleasure, and thanks to the whole team at the International Society for Neglected Tropical Diseases for inviting me, but also inviting MSF onto this platform to speak about a disease that we're very passionate about, but it's also neglected around the world. During the video, I was just looking through the chat comments, and I got to see that there's a few people coming in from Nigeria. So it's really great to have some of our Nigerian colleagues here with us today. And I do see a presence of some of our colleagues who are actually working in the hospital in Nigeria that looks after the Noma patients. So a big welcome to all you guys from the field as well. So this presentation is going to be based on a little bit more of the operational research that we're doing in MSF and in Nigeria specifically. And it's going to go through some of the studies that we've performed over the last few years. So we'll run through it, and at the end, hopefully there'll be lots of time for questions and to discuss some of the bigger issues around Noma. So what is Noma is the big question. So Noma is also known as cancrum oris. So it's an infection of the oral cavity, which causes a disintegration of the cheek, and in some cases the nose and the eye, in just under a week. So if untreated, Noma has been reported to have a mortality rate of up to 90%. and this mainly affects children aged between the years of 2 to 5. With timely antibiotic treatment, wound debridement, and nutritional support, morbidity and mortality from Noma greatly decreases. But for those who survive, Noma leads to severe facial disfigurement, and obviously then there comes with that huge amount of stigmatization in the community. And Noma typifies the complex interactions between malnutrition, poor sanitation, poor oral hygiene practices, and immunosuppression. The word Noma is derived from a Greek word meaning to devour. And this symbolizes the rapid nature of the infection. I said 1 week, and the damage is largely done with a high mortality rate. But Noma has been around for centuries and was reported by physicians going back to Hippocrates and Galen. And currently, Noma is commonly reported in low and middle income countries in Africa and Asia. But it has also been reported in the US and the UK in the last 5 years in immunocompromised patients. So moving on to the stages of Noma and a little bit more on the epidemiology. So the WHO classifies Noma into stages from stage 0 up to stage 5. So starting with the simple gingivitis up to acute necrotizing gingivitis, edema, gangrene, scarring, and the sequelae. And the top part of the diagram here, you can see from day 1 to day 2 with the red bleeding gums. But moving very rapidly across to day 8 to day 10 with a lot of destruction and gangrene of the cheek. So the WHO estimates that 140,000 new cases of Noma occur annually. And Noma cases are frequently reported in Nigeria. A 2019 study in north central Nigeria, and this was based on patient records, estimated the period prevalence of Noma from 2010 to 2018 was 1.6 per 100,000 population at risk. The Nigerian Center for Disease Control, or the NCDC, has recorded 38,000 Noma cases from 2011 to 2017. However, they believe this is very much underestimated of the true burden of disease that actually exists in the community. And the largest number of cases reported in Nigeria are in the northwest and the northeast of the country. So the Noma's Children's Hospital is in Sokoto in northwest Nigeria, you can see here on the map. And this has been providing treatment for Noma patients for many years. And since 2014, MSF has supported the programs at the hospital. And these programs include surgical interventions, nutritional support, psychosocial support, physiotherapy, outreach, and operational research. Excuse me. The main strategic goals of MSF at the Noma project are to increase the access to specialist care, to increase awareness about Noma, and to facilitate early detection and promote prevention through outreach activities. We want to identify and strengthen local capacity through training and preparation that we will hand over the MSF activities to the Nigerian authorities and other actors. We want to identify and fill gaps in knowledge about the disease. And lastly, we want to advocate for the inclusion of Noma in the WHO neglected tropical disease list. And this is an important component of what we're trying to achieve as well from an advocacy perspective. In the video that introduced us, who so eloquently introduced us to the topic, and this is a video which has been screened at the Health for All WHO Film Festival a number of weeks ago. And in this story, it showed Belia as one of the people in the video. And this brings in a little bit of the human aspect into this presentation. I want to just make sure that throughout this presentation, you think of stories like Belia, who's unfortunately one of the lucky 10% who actually survived the childhood infection that he went through. And so Belia is a 20-year-old guy from a village near the border with Niger. And he waited almost 4 years for his first surgery. And Belia thinks he first contracted Noma when he was just 1 year old. Outside his village, people would run away from him when they saw his face. And he told us they didn't see me as a human being. And you can imagine the stigmatization that occurs from this debilitating disease with huge mortality, but also for the survivors, huge morbidity, especially psychological morbidity. And I just want this very brief story, just to frame the thinking as we go through this presentation and why we undertake the work that we do. So today our focus will be on the studies that have been conducted by MSF in Nigeria. And these studies form part of the overarching operational research agenda for Noma, which aims to add to the scant body of knowledge that exists on Noma and provide useful information on the disease for program planning and advocacy. And the main gaps in knowledge around Noma are the true burden and distribution, the mortality rate, and the pathogenic sequence of the disease. In addition, the long-term outcomes after care and effective prevention methods also needs to be explored further. So this is why we have engaged in so much operational research on this. The operational research agenda has so far encompassed 5 research projects, 2 qualitative studies, one on traditional healers' perceptions and treatment practices for Noma, and the second exploring the language and beliefs about Noma and with caretakers of Noma patients and healthcare providers at the hospital. The other 3 studies are quantitative and assess the risk factors for diagnosed Noma, the long-term outcome of patients operated on at the hospital, and the prevalence of Noma in Sokoto and Kebbi states, which is the state next door to Sokoto state where the hospital is. And the research agenda is based on the socio-ecological framework of factors associated with Noma. And the diagram on the left of your screen is adapted from similar frameworks used for public health studies. And Noma is a disease associated with factors on multiple levels. A lack of societal services and high poverty levels on a society level, high unemployment levels, environmental factors impacting food production and distance from care on a community level, a lack of access of care and low socioeconomic status on a family level, and finally, poor oral hygiene and malnutrition on the individual level. The operational research agenda projects include participants of all levels, including the individual, the family, the community, and the society. So by including a variety of respondents in the projects, we aim to identify potential intervention points which may offer wide-ranging support for the prevention and treatment of Noma. So of course, I just want to make, just for considerations, of course, ethics has been obtained from the MSF ERB, but also within Nigeria as well. Consent and where applicable assent has been provided from all our patients for this work. And also to point, we use some photos from the project and from the work that we do in this presentation. And consent has been taken for the use of these presentations in external communications. So the first study I want to talk about was conducted in 2017, and that was the risk factor study. And in this, we aim to estimate risk factors for diagnosed Noma to better guide existing prevention and treatment strategies using a case-controlled study design. Cases were patients admitted between May 2015 and June 2016 who are under 15 years of age at reported onset of the disease. Controls were individuals matched by cases to village, age, and gender, and caretakers answered the questionnaire. Risk factors for diagnosed Noma were estimated by calculating unadjusted and adjusted odd ratios and respective 95% confidence intervals using conditional logistic regression was used. So coming on to our findings, we included 74 cases and 222 controls. Both groups had a median age of 5 years. 6.5% of cases and 16% of controls had a vaccination card. Vaccination coverage for polio and measles were below 7% in both groups. The two main reported water sources were a borehole in the village and a well within the compound where the household was. The adjusted analysis identified potential risk and protective factors for diagnosed Noma, which need further exploration. And these include potential risk factor of the child being fed PAP every day, And pap is a porridge made from normally maize, but also can be used from lots of different grains, such as sorghum. And this is commonly used in Nigeria. And potential protective factors include the mother being the primary caretaker, the caretaker being married, and colostrum being given to the baby at birth. And looking at the interpretation of these results, so similar risk factors have been suggested in other studies, including the absence of breastfeeding and dietary habits. Further reported risk factors include unsafe drinking water, limited access to high quality healthcare, high infant mortality, and food security. So one novel observation of the study was the possible protective nature of colostrum. There are inherent health benefits associated with colostrum, as it is rich in antibodies and confers passive immunity. And several published case reports on Noma have highlighted a relation between Noma and contaminant infections. And these studies suggest that immunosuppression plays a role in the causal pathway of Noma development, which supports further the finding of the protective nature of colostrum. So this study has shown the social conditions and infant feeding practices that are associated with a diagnosed Noma case in northwest Nigeria. But moving on to the kind of looking at the more holistic and the bigger picture of Noma, this moves on to the language and beliefs study. So this is the second study that was performed, and it was a descriptive qualitative research design to explore the language used to describe Noma and the beliefs around disease in northwest Nigeria. And to do this, 5 focus groups were held with caretakers of Noma patients admitted to the hospital. And at the time of interview, 12 in-depth interviews were also held with staff at the hospital. And both the in-depth interviews and focus group discussions were carried out using open-ended interviews. And the topic guides used were adapted to encourage the natural flow of the conversation. The choice of methods was used to gain a rich understanding of the topic, though through assessing the patient and practitioner perspectives of the disease. And interviews were conducted in the local language Hausa, and they were recorded. And these recordings were transcribed into Hausa and then translated into English by the research assistant Aisha, who actually is featured in the picture on the screen. And the data was initially managed through reading and rereading all translated transcripts. And the investigators analyzed the data by highlighting words, phrases, and paragraphs, which were then emerged into codes that were constantly compared by the team. And the patterns and themes were then deciphered into codes. So the results of this is, I find really, as a physician, I find this really interesting, looking at the community aspect. So our study encountered 2 main themes. And number 1 was names, so the description and the explanations of the disease used. And the second is the risks and the consequences of Noma. So to start with the naming. So naming of the disease differed between caretakers and healthcare workers. And the most commonly used name among the healthcare workers was Noma. There were only a few overlapping terms, as you see on this left table, used by both groups, as such as Kiwan Daji, a broad term that means a cancer of the body. And names form a part of the understanding of the disease in this setting. The broad names used for Noma, such as Kiwan Daji, are described in association with the beliefs and social system used to explain the disease. Caretakers shared several beliefs on why and how the disease is caused. The 3 causative categories that were identified were spirits, such as jinn, living creatures, such as insects and animals, and the connections with previous illness. Jinn was described as the world of other creatures that we cannot see. It is the belief that there is a spiritual realm all around us, filled with normal people all leading normal lives. There are good jinn and there are bad jinn, and jinn can enter human bodies and cause harm. Difficulty in accessing care for Noma patients was evident, and the findings suggest a variety of actions taking place before reaching the Noma hospital, and visiting traditional healers, community health centers, and private doctors. Limited access to prescribed medications was also reported within this group. So barriers to care and lack of knowledge and trust were mentioned by participants as well. So the impact of Noma is not just limited to physical presentation. Participants in our study spoke of the strain on their mental health and the disease placed and how the stigmatization placed on the caretakers and the families was a key point to ongoing difficulties that families faced in the community. And carers and practitioners' perspectives may enlighten efforts to improve case finding and to understand healthcare access barriers. So differences in disease namely illustrates the differences in beliefs and how this has an impact on health-seeking behavior, and for which Noma cases has severe ramifications due to the rapid progression of the disease. If people aren't presenting to healthcare fast enough where you can actually treat the disease, unfortunately, this is where the mortality happens. So understanding these beliefs is very, very important for us to develop messages and advocacy in order to actually counteract this. So the third study performed was the traditional healer study. And this was the third study conducted in 2018. And the aims of this study was to explore caretaker and traditional healers' perceptions and practices towards Noma and the influence these have on health-seeking behavior. So to do this, we conducted a qualitative study utilizing in-depth interviews with 12 caretakers of patients admitted to the Noma hospital and 15 traditional healers in the Noma villages, in the home villages of patients in Sokoto state, where the majority of Noma patients come from who enroll at the Noma Children's Hospital. And again, the interviews were conducted in Hausa and audio recorded by Husina, who is pictured in this picture at the back. Data recordings were transcribed into Hausa and then translated into English. And data saturation was discussed between investigators. And once this occurred, data collection ended. So transcripts were manually coded and the codes were then discussed with the research team, and thematic analysis was undertaken to identify patterns throughout the data. And looking at the main findings of this, three main themes emerged. Number one, the role of experiences of traditional healers, particularly in the management of Noma cases. Number two, the relationship dynamics between caretakers and traditional healers. And number three, the knowledge and perceptions of Noma and treatment practices for the different stages of the disease. So very interestingly, traditional healers reported that they played a specific role in the community. They were well known and believed that their healing skills were understood and appreciated in the areas where they lived. Traditional healers reported learning their craft in different ways, including inheriting from family members, but also through dreams and spirits. Traditional healers offered specialist forms of care for specific conditions and referral guidance who believed that Noma was caused by previous illnesses. So traditional healers viewed the stage of Noma as different conditions with individualized remedies. And very interestingly, healers most often treated the earlier stages of Noma, particularly gingivitis and edema. But very interestingly, they referred children with the later stages of diseases to the biomedical healthcare centers. So for me, that's a very, very interesting aspect. So traditional healers could play a crucial role in the early detection of Noma and the health-seeking decision-making process of patients. They could really play an active role in this. So intervention programs should include traditional healers through training and referral partnerships. And this collaboration could save lives and capture patients early and reduce the severity of the Noma complications. So one of the bigger studies I want to speak about, and it's a recent BMJ Global Health publication, is the prevalence study. So this was the fourth study that was conducted at the end of 2018. And in this, we aim to estimate the prevalence of Noma in Sokoto and Kebbi states using a cross-sectional study design. We conducted village geosampling using satellite imagery, and from there we created a sampling frame of villages by ward, which is a smaller area, in Sokoto and Kebbi state using geo-sampling remote sampling methods. The OpenStreetMap database was compared against freely available satellite imagery, and to identify and verify village geolocations and to add new villages on the list. The number of clusters of villages per ward was selected proportional to the population size of each ward, which that data we had separately published. And villages were then chosen at random. And once each teams arrived in the village, they introduced themselves to the village chief. And compounds were selected using WHO EPI methodology. And then from there, households in each compound were then selected using a random number generator. And all individuals aged up to 15 years were selected to be included in the study. So caretakers answered a structured questionnaire, including questions on socioeconomic status, living conditions, vaccination status, oral hygiene practices, feeding practices, and what their access to healthcare was like. Oral screening was conducted by our medical staff using the WHO Noma classification system. Mid-upper arm circumference was taken for children between 6 months and 5 years, which is screening for malnourished children. And from there, a weight analysis of Noma prevalence and severe and moderate acute malnutrition was conducted. So in order to analyze this, single and multivariate analysis stratified by age group was conducted using logistic regression to estimate factors associated with the prevalence of Noma. So this table looks at the demographics that we recorded. So we included 3,499 households, sampling 7,122 individuals. 98% of caretakers were female, and the median household size was 5 people. 60% of included children were aged between 0 to 5, and 52% of them were female. So simple gingivitis was identified in 3% of the children, acute necrotizing gingivitis in 0.1%, and edema in 0.05% of children. No late-stage Noma was detected in our study population. However, it was seen in the villages, but these houses were not picked up in the random selection. And the prevalence of severe acute malnutrition was 4%, and moderate acute malnutrition was 8%. So the univariable analysis of risk factors for stage 1 and 2 Noma showed that having eaten pap, so this porridge, in the last 24 hours, or the eating of pap once per week, and the caretaker preparing pap once or more per week, compared to less frequent preparations of pap, were associated with not having stage 1 or 2 Noma. The child experienced an illness in the last 12 months prior to the interview was associated with being actually a stage 1 or 2 Noma case. Looking at the 0 to 5 years age group, in this group, having a well as drinking water source and being aged 3 to 5 was associated with a higher Noma prevalence. Then looking at the older age group, so the 16 to 15-year-olds, the multivariate analysis showed that being male was associated with higher Noma prevalence, and preparing pap once per week or more was associated with a lower prevalence of Noma. So then coming on to what does all of this mean? And so based on the study results, we estimate that 129,120 people or individuals less than 15 years of age would have had any stage of Noma at the time of the survey within the 2 states. And this study has shown that the prevalence of any stage of Noma is higher than in previous estimates. Study findings actually indicate that children aged between 3 and 5 are at have a higher prevalence of Noma in comparison to those aged 2 or less. And this is corroborated by other studies and is likely due to the relationship between child feeding practices in Nigeria and malnutrition as a risk factor for Noma. We showed various factors relating to pap preparation and consumption, and they were linked to Noma. And this may be due to the lack of access to food, or that pap has more frequently has less chance of becoming contaminated, thus causing less disease. Because the longer you store pap, the higher the risk that it gets contaminated. And this study further indicates that having a well as a main source of water is being associated with Noma. wells are associated with being contaminated through animal feces and waste products, but also through seepage and leakage of pit latrines into the water source. So this could be causing the link between the wells and the higher prevalence of Noma. So while we did not find any later stages of the disease, high rates of simple gingivitis in the presence of known risk factors of Noma, such as low vaccination rates, malnutrition, and poor access to healthcare, suggests that the need for improved coverage of preventative interventions and access to care in Northwest Nigeria is of extreme importance. So it's very important, and this is coming back to our advocacy message. Noma meets the criteria of a neglected tropical disease as defined by the WHO. It is a preventable disease that affects children in low resource contexts. Children that survive will have lifelong physical and mental health sequelae. And there is a poor understanding of the disease, its pathogenesis, and its global burden. The Noma prevention and control will require a concerted health systems approach. So adding Noma to the WHO list of neglected tropical diseases will facilitate global attention of Noma, but also hopefully allocate a much needed resource boost to the countries where Noma contributes to the public health problem. So now coming on to the kind of one of our kind of final studies, which is actually ongoing. So I won't be really presenting much on data on it, but it's the last study, and it's called the Outcome Study, and this is a multi-year study which began in 2017, and the data collection for this is, as I said, is still ongoing. So the aim is to retrospectively assess previously cared for patients that were in our cohort in the hospital and set up a prospective surgical outcome assessment of the program. So the study was made up of two sections, and the first was a retrospective assessment of patients operated on with a focus on mouth opening, quality of life, and survival rates after treatment. So data collection for this portion of the project has already been complete. The second is a prospective assessment using a standardized tool. And assessments were conducted at admission, pre-op level, and at discharge, and at 6 months and 12 months after the date of their last surgical intervention. And data collection activities for this are still ongoing. The retrospective data collection is complete, and the results are currently being written up for a case series, which is currently under review. But I'll briefly just go over those results. Of the 37 patients included, 57% of them were male, and 63% of them were aged 6 years or older. At assessment upon admission, the most severely affected anatomical area was the outer cheek. 36% of patients had lost between a quarter and half of their cheek. That's a huge portion of the cheek that was missing, which is quite astounding. 32% of patients had one surgery, and 40% of patients had 2 to 3 surgeries. The most frequently used surgical procedure was a deltopectoral flap, and trismus was released in 32% of patients. So trismus being kind of a tight jaw or locked jaw. All of the respondents reported that the surgery had improved their quality of life. But despite no evidence that the trismus or the lockjaw element of patients had improved at follow-up, most respondents reported improvement of the quality of life, like I said. So our findings indicate that a strong need for focus on post-operative physiotherapy to improve mouth opening and reduce occurrence of trismus. These findings also indicate the need to establish a routine follow-up system with patients in the community, if possible. Enrollments in the prospective cohort are complete, and patients will be followed up for 12 months after the date of the final surgery. And analysis of the results will take place at the end of the follow-up period. So this part of Nigeria is not the easiest place in the world to do research, and there's several limitations for this for that impacts our studies. Number one is the high security situation. Security is insecure, so it makes going to the community and interacting with the community better. It makes that challenging and quite difficult. The road infrastructure can be very poor, so also this brings many logistical challenges to the work that we do. Due to the rapid progression of Noma, there is a chance we only include a fraction of the actual cases in the studies, And this could lead to a really underestimation of the prevalence of Noma that we are reporting. Loss of follow-up is an ongoing issue in the outcomes study, and that's something that we're looking into further. And social desirability bias could have been introduced in the qualitative studies, as could survivor bias, as the caretaker interviews were limited to those who sought care and were alive at the time of interview. As I said, only maybe 10% of people survive the initial infection. So there could be some bias actually related to this as well. So there's some ongoing research into other research into 2020 and 2021. However, COVID has, of course, changed our timelines for this research. The first is a phased study assessing the knowledge, attitudes, and perceptions of Noma. This study will be conducted in close collaboration with the Nigerian Centre for Disease Control. Phase 1 will include healthcare workers at the primary, secondary, and tertiary levels in Sokoto and Kebbi states. And phase 2 will include NCD surveillance officers. The second study will assess the proportion of pediatric admissions at the Anka General Hospital. So this is a hospital that MSF runs in the region, a general medical hospital for children. And we will assess Noma data over 3 months. So we'll assess differences in Noma proportions between malnourished and autistic children. So hopefully this study will give us insight into the burden of disease, but also to offer insights into the relationship between malnourished, malnutrition and Noma. The third and final study will be to assess the medium, so we say 6 months, outcome of patients admitted to the Noma Children's Hospital with stage 0 to 4 Noma, and to explore factors associated with positive outcomes after treatment of stage 0 to 4 Noma. So that's important because a positive outcome will be firstly, a positive outcome will be defined as a patient who is alive and has not progressed to stage 5. But this is different because this will give us insight to a rarely studied people, which is those that have survived the earlier stages of Noma. So this will give us insight into these earlier stages. So this is kind of an overview of what we've been doing. There's been a huge range of authors and contributors, I should say, to this research, from MSF, from a HQ level down to the international and national staff in the field, but also, as I said, close collaboration with the Ministry of Health and the Nigerian Centre for Disease Control. Go into the different studies. These are the authors that have been involved. So the papers that I mentioned and the research that I used, these are the references for them. If you would like to read them and cannot access them yourselves online, please get in touch. My email's on the next slide, and I can distribute them to you. Be very glad to do that. My contact details is here. Our research coordinator for Noma, she will normally provided given this presentation. Her name is Elise, and this is her email address here. She is on maternity leave currently, but she was the focal point for the Noma research and fast becoming into a very much a global Noma expert. And then this comes into a very big thank you to everybody who's been involved in this research and the ongoing Noma work. And this is a picture of all of our staff and workers in the Noma project. It's a really, really nice way on one screen to have everybody on the screen, and so we can say a big thank you to every one of them for the hard work and dedication that goes into providing the difficult surgical, medical, but also community care that goes into delivering this kind of life-saving program. So a big thank you to all of them. And that is it. And I think one last point would be, we do have going back to the video. Claire, who was the producer of the video, who visited the field to make this movie a number of times, is also available to give a few comments on her experience of producing this work, but also then she can answer some questions that are related to how we went about this. So again, one final big thank you.
Well, Mark, it's a very, very big thank you from us as well. That was a really great overview of not only the burden of the disease, but also what MSF has been doing in field, as well as in terms of operational research, but also charting out what are some of the priority areas for the future of Noma control. I think you've given us a lot of food for thought. One manifestation of that is that the people who have been asking questions on the chat have tended to ask one and then several. So we'll have plenty to discuss there. And also, very interestingly, some of our attendees said, thank you very much for this presentation. It's actually the first time I've ever heard of Noma. Despite, of course, this being a meeting of professionals and people who have been in this field for a very long time. So thank you very much, Mark, and thank you to MSF for putting this disease really at the forefront and for all the work you've done. So I'm just going to turn over to the chat now for to take a few questions and hear a bit more from our attendees. So again, really fantastic turnout from all over the world. We have colleagues tuning in from Brazil, Cameroon, Benin, Geneva, Bangkok, and of course Nigeria with I think some colleagues and friends, Mark, tuning in, including Semu Adeni from the Children's Hospital Sokoto, which you mentioned, you highlighted quite frequently there. So I guess to start off, there was a question here asked. Of course, I've now lost it because the chat box is one of the smallest things on earth that you would probably need a magnifying glass to really take it, but I found it now. So first question here from our colleague and friend, Rita Oliveira. Hi, Rita. Rita is with the Children's Investment Fund Foundation based here in London. And Rita was asking, great question, actually. Do we know the prevalence of this disease in other countries in Africa and globally?
No, very good question, but the answer is no. In terms of the literature, there's very little out there, and most of the literature that you would find is actually just a case series or a case study, and you see that from certain parts of Asia and other parts of Africa. I know, working in South Sudan previously, the first time I even heard of Noma was a patient presenting to me in a pediatric hospital in South Sudan, and I know it goes very much under the radar. So no, the short answer is no. We have no idea. And that is why kind of work such as our prevalence study is so important to actually try and develop that knowledge base, because we really need to get that information out there. We know it does exist. It existed in the UK in the 1800s and early 1900s. It does exist around the world, but because it's such a disease with, I guess, such a high mortality rate and so quickly, it affects the poorest of the poor. So a lot of these people, unfortunately, go under the radar of health facilities and unfortunately do not get picked up. But what I would add is that we have now got, in Nigeria, we've got Noma as one of the diseases that the Nigerian Centre for Disease Control has as part of their surveillance system. So we have now embedded that in their surveillance system. So now we're starting to develop better real-time data. So depending, I guess, on how this goes, we can start advocating for this to be rolled out to other more prone countries. But very good question. A lot of work to be done.
So is it that mostly that this is not something that's being necessarily looked for, or is it just that there hasn't been any kind of evidence or mention of it occurring in other regions? Even, I'm thinking even in across Latin America or entirely different continents.
Yeah, because it's not on the surveillance system, so it's definitely not being looked for. People don't know about it. People really do not know about it. And but anybody who does see it, you normally get it. You tend to see it when it's at its the patient or the child is survived, is okay, but is left with the deformity. And at that point, there's not much more they can offer to do. I mean, they probably just send the patient home, likely not knowing what it is. So there's a lot of awareness about what the actual disease is. But it comes back to, we need people to be able to identify it very early, because the prompt management, antibiotic use, oral hygiene, and nutrition saves lives. So that's we need to raise awareness and then get those simple methods in place so we can intervene quickly.
Absolutely. And you mentioned nutrition there, and there were a couple questions actually that piqued the attendees' interest about the role of PAP and how can this be a risk factor of Noma. This is a question from Huguette Simo, who's tuning in from Cameroon. Hi, Huguette. And again, echoed a similar question. Semiu Adeni from Nigeria was asking, since PAP was the main food after weaning, how will nutritional education help in preventing acute Noma in local language and using local food materials?
Yeah, no, very good. The reason, coming to the first question first, the reason PAP, the links to it is, number one, it's likely got very little nutritional value. So the PAP, so being eaten, there's an over reliance on one sole food type with a low nutritional value is number one. And then number two is sometimes PAP is formed, is made, but then it can be stored for longer periods of time, 7, 10, 14 days. And it can be very prone to contamination from other bacteria, such as Salmonella. And Salmonella has been linked to the progression of, as one of the pathologies that can be linked to the rapid development of Noma. So there is, we think that that's where the links there as well are too formed because of PAP. Very good question. In a setting like Northwest Nigeria, where PAP is the sole kind of weaning food, our assumptions and our recommendations or our viewpoint is that we need to kind of look at what's available in the wider kind of agricultural availability locally. But I do acknowledge that can be very difficult because the diversification of the grains used can help with micronutrient and for the nutrients that the child is getting and build up the immune system in that way. So a varied diet used for weaning would be the ideal situation. But of course, we're looking at a region which has got high poverty situation, so that's much easier than it actually is to do. But I think there is definitely room, very context specific actually, looking at how we can adapt nutritional advice and health promotion to mothers and families and fathers on what food they should be providing. But that's a very good question. I think that is another area where more work is needed as well. And like northern Nigeria is very different, say, to Laos in Southeast Asia in terms of the food types, where that's another place where there's a lot of case reports of Noma. So I think it very much has to be context specific. So that has to be, those guidelines have to be kind of made locally. But very good questions. Yeah.
Stephen Bramer, who works in insect and pest control, and I believe is based in Ontario, Canada. Hello, Stephen. Is asking, have you identified any specific causative and associated microorganism in patients?
Yeah, so there has not been any that I know of very good formal kind of microbiology studies that look at, very high level studies that look at this. But the bacteria that we think is, I cannot list the names, I forget the names off the top of my head, there's a long list, the long names of bacteria, but they tend to be the normal flora that live in the mouth. So it tends to be microbes that are actually already existing, not coming from an external infection, for example. However, so that kind of shows like the role of the body's own immune system and how malnourishment comes into play. But also then coming back into the PAP situation, so microbes added that are contaminated in food, such as Salmonella, have been shown to rapidly progress Noma. But the jury is very much still out there on. We have a list of microbes, but the interaction between them and how it works is still very much unknown.
Right, very, very interesting. And just a question, just kind of tying into the PAP. Emmanuel Agunloye is asking, since Noma is caused by nutritional deficiencies immediately after weaning from breastfeeding, what is your recommendation towards the provision of protein supplements that can be added to the staple food PAP for the children?
I don't know if it's just protein. I'm not a nutritional expert by any means, so I'd have to refer to my nutritional colleagues on how to best formulate that. But that is one side of it. But it's also you have to look at more than protein, but it's more the micronutrients as well, and the magnesium, the zincs, and folate, and so on and so forth. So you would have to look at a bigger picture. And I know that, of course, there's endless amounts of research being done on malnutrition, how to treat malnutrition. So in the patients that present to us, of course, we use the malnutrition product Plumpy-Nut extensively in the Noma hospital for treating malnourished children with Noma. So that is a product that can be used to treat malnutrition. However, that's not a project that replaces a normal diet. That has to be used more in an acute situation. But no, there is, but all of these good questions just really highlights the amount of gaps in knowledge that we have on Noma and the amount of work that needs to be done. And also, as MSF cannot do it alone, and we're slowly trying to build up the picture. But we need expertise from very, very different angles to actually investigate this. But nutrition is important, but we're looking at a very bigger picture, societal issues, poverty, economic status, that all plays a very big role. And when you put all that together, it's a lethal mix, I guess, for developing Noma.
Another kind of field that is heavily involved in the start of Noma is that of oral health, and there were a couple questions here about on that topic. So William Van Cleve, and please, when you ask a question, if it's all possible, do include your organization or where you're tuning in from. That's always really interesting to know. So William was asking, the prevalence of gingivitis, which is Noma stage 0, was about 3%. Do you have a sense of whether this is higher or lower than other similar contexts where later stage Noma is less common? And also kind of a slightly related question from Ife Adetula was just asking, where there is no oral plaque, do you find cases of Noma?
So back to the first question. No, at the top of my head, I don't know. That's a very good question, and that would be quite a nice addition to the study in a sense of comparing it to a non-Noma setting where we know there's no Noma, and comparing the prevalence of gingivitis. However, I think that would be difficult to do because I think Noma is, especially if we look across that sub-Saharan African context, especially across Nigeria and going across, I guess, Southern Sudan, South Sudan, Ethiopia, and Central African Republic. Noma probably equally exists there nearly as much as Nigeria, but it's underreported. So how to compare that in a very like-by-like context, I think would be quite difficult. But it's a very good question, and the answer is I don't know the answer to the prevalence of gingivitis amongst, a non-Noma cohort, because that would have to be matched in a very similar context. The plaque, I don't think plaque is so much related, because we do see cases in children of very young age with very, very immature teeth, where they have not actually gone on to develop a full teeth, like a mouth of teeth, but also larger teeth. So of course there would be plaque available or there, but I don't think it plays a role that you think. Of course, a plaque is characteristically a chunk of a polybacterial mass, but there hasn't been any evidence to date, at least, of plaque being linked to Noma directly. And what goes against that is the younger age that you can see this happening. However, I'm sure it does mix, especially for the older children who develop it. I'm sure it is a factor that links into that. But of course, then that links into good oral care. With good oral care, you'd have a decreased prevalence of plaque. So I am sure there's a link of some sort, but it hasn't been proven.
And definitely some partnerships that are that could be explored there. That would be, especially
from a health promotion perspective. Yeah. The difficulty, I talk about community engagement and health promotion. One of the big difficulties, as I alluded to in the presentation, was the ability to actually get into the community because of security concerns. So, you know, we have to be creative and inventive in order to come up with strategies that will actually get into the community.
Great. And Ife Adetula was saying, thanks for the response to the question. And William Van Cleve was just highlighting on the chat. He's saying, I'm from the US and have worked in Sokoto with MSF.
Oh, good to have you. Thanks.
It's one big family.
You can probably answer some of these questions as well.
Absolutely. And just following up on this, Emmanuel was adding that gingivitis is also caused by flagellates and entamoeba. These are also high in fecal materials in herds. Could there be any correlation? It is known that flagellates could hide gonococcus in man. Could oral flagellates, sorry, this second half of the question is gone. Could oral flagellates also help to transmit those bacteria listed in Noma disease? So,
good question, and the answer is I don't know. It sounds like he's actually a microbiologist or a very well-educated non-microbiologist who knows the area well. I don't know. I presume all of this is possible. And it really, these very, very educated comments, especially on the kind of polyform or polybacterial construct of this, it really highlights the gulf of knowledge that is, or lack of knowledge that is there, and how we need to look into this a bit more, into deeper. You know, in I think in the risk factor study, we did identify that a lot of work on the pathogenesis of this is required, and great questions like this is all part of the of that question. So no, the answer is I don't know. I assume it is, and more work is needed.
Absolutely. Well, there's certainly a lot of discussion on the chat here. There's also been quite a few posts by Dr. Marco Caminiti, who has done a lot of facial surgery. So I do invite you to go over to the chat, to all our attendees, and find out a little bit more. Marco's also written a book. And so I'm sure Marco, but also within all of our attendees, there's a lot of opportunities there for discussion and for knowledge sharing. So by all means, keep in touch after this webinar. And Mark, you've kindly put up your contact details as well, and don't hesitate to get in touch with ISNTD as well if in any way we can connect you. There's been quite a few questions actually, specifically about the beautiful film that we watched right at the beginning. And so I thought this would possibly be a great time to bring in our friend and colleague Claire Jeantet, who along with Fabrice Cantarini from Inediz production actually put together this magnificent film. And so I will just try and, with technology hopefully being on our side, I will just bring Claire into the discussion and hopefully Claire will be able to answer your questions directly. Lots of people on the chat saying, thank you, Claire. Thank you, Mark, for a great talk. And also asking about when and where they could watch the full Restoring Dignity film. Claire, hello.
Hello, everyone.
Nice to see you. How are you doing?
Very fine, thank you.
Yeah, I think you're speaking from France.
Exactly.
Claire, so thank you for your film. Thank you for taking us on that journey. I've actually seen the full feature documentary, Restoring Dignity. This was shown at our annual festival where we bring together film and photo, apps and games and all sorts of creative materials around tropical diseases and science communication and public engagement. And in fact, it was such a compelling film and it was so moving that we really didn't have a choice but to give you an award for this film, and which has already won many awards and in fact was selected as a finalist of the recent World Health Organization Film Festival as well. So congratulations on all the things you've achieved on the journey to becoming a real ambassador for this disease. So Claire, a few questions here from our audience, which I think you've seen on the chat, but not everyone's on the chat. So perhaps you could tell us a little bit more about how the film came about and how, what are a few memorable thoughts about this in terms of disease advocacy, and also on a practical level, is there any way to watch the full feature for those who wanted to find out more?
Oh, sorry, I didn't catch your last question.
Just about if people wanted to find out more and watch the whole movie, how would this be possible?
Okay, thank you. So I have just written in the chat my email address. So please, if you would like to host a screening of the long-form documentary, get in touch. This is something we have been doing a lot to make it accessible for people in medical universities and hospitals across the world, and in particular in Nigeria and in different regions. So please get in touch. I will be happy to make it possible. So I have been working on this with my colleague Fabrice Caterini for 4 years, almost 4 years now, in collaboration with MSF and all the staff at the Noma Hospital. It has been like a very interesting and shocking thing for us to realize that Noma is preventable and treatable, and it still kills so many people across the world and leaves survivors with disfiguration and a lot of difficulties. So I'm very much committed now to keep the story alive and do everything I can for those stories to be heard. We have worked with Fabrice in a very collaborative process with the patients at the Noma Hospital and the one we met in different villages around Sokoto. We wanted to make sure that at every stage of the filming process, they were really on board. And one of the things we have been doing is sharing with them pictures, printed pictures during the process. And we are still even in touch with some of them, receive news from them thanks to the staff of the Noma Hospital. I have noticed we have some people here from Sokoto, so a big hi to everyone there. We miss you very much, and we are still very much committed with Fabrice to make those stories heard and be sure that this process worth it and we can help raising awareness on Noma.
That's fantastic. Thank you, Claire. And it's just really the start of a journey, I suppose, for yourself, for MSF. We still a lot of ground to be covered in future. An interesting comment here from Ife Adetula, who's adding, from places where cases are seen, it has been documented that people often share a source of drinking water with animals. So again, perhaps exploring collaborations with the One Health and veterinary fields is another area where we can try and answer some of the gaps that remain. We're kind of coming up to the end of our time for this webinar, but while we have you both here on screen, perhaps it would be a good opportunity to ask, although Mark, you did outline some of the research that you've got planned for the future, but perhaps sort of on a broader kind of more, more on the side of advocacy in a broader way, what would you like to see happen next in terms of Noma? Control, awareness, prevention. You come from very different backgrounds. One's on the medical side, one's on the creative side. So what would, in an ideal world, be your next steps?
Claire? For me, I think from an advocacy perspective, the next big goal is the further highlighting at the WHO level and our push to have Noma on the WHO neglected tropical disease list. We would see this as a platform which I know when you were with the talks 2 weeks ago with the director of the WHO of the neglected tropical disease team, I'd kind of said like the getting onto the list is not the holy grail, but we feel that with getting the Noma up into that list, it really highlights, if nothing more, it really does highlight to a wider audience the the name, but also the existence of this disease. And with that would come, hopefully, higher funding from other actors. Because what we need in the longer term is greater awareness. We need people to know. We need more people to know who work even in the international community. We need to know. I give the example that I had training in tropical medicine. I never heard of it until I was in South Sudan when a patient turned up to the clinic I was working in. So, and if me with some great education in this medical sense, like if my eyes are still blind to it as well, God knows for people who are not in the medical field, for example, like they just don't know about it. So for me, is piggybacking onto Claire and onto the creative side, and getting like really good creative and messaging that people understand and can relate to, and getting that into a widest community as possible is what I would like to see happen over the coming year, and especially on the WHO lobby as well.
How about you, Claire?
No, exactly. I agree with Mark what you just said. And what I have witnessed presenting the documentary in various contexts and countries during last year, something which is a bit on hold now with travel restrictions, but of course we can find new ways of sharing patients and survivor stories, and using those stories and showing them to the audience. I realize people really keep it in mind, just also like Mark was saying with Bilia's story at the beginning of his presentation. I think having in mind the story of a patient, and I know, Marianne, that you also had one in mind after seeing Restoring Dignity, and this is something that stay with you. And sometimes people write to me a few days after watching the movie, and they offer to screen this documentary in their own hospital or university. And this is this kind of virtuous circle that we are trying to do by relating to those human stories and sharing their words with as many people as possible.
That's really brilliant. That in mind. We're coming up towards the end of the webinar. You've given us, really a lot to think about, all the way from those of us who are very new to the field of Noma, who heard about it, or those who are, kind of well-versed knowledges that we heard about earlier in the session. I'm really sorry we didn't get a chance to come down to all the questions that have been posed. Helene Oliartha was asking about perhaps the relationship with other febrile illnesses preceding the Noma infection. And we also had a question here looking at the relationship between HIV and Noma infections. There's still a lot of material to explore, and all I can say is I apologize that we couldn't get around to everybody. However, by all means, this is only the beginning. I think we can agree to that, Mark and Claire, and please do keep in touch and continue discussions, and definitely we will be back for more Noma advocacy and as a follow-up research. Before we go, I'm going to share the BMJ Global Health number that Mark was mentioning. So this should now be with all of you, and please download it directly to your phones or your computers. It's a great piece of collaborative research between MSF, but also a huge number of partners, both in Nigeria and other countries. I would just like to invite everyone to join to us here at ISNTD to thank you again, Mark, and thank you, Claire, for your participation today. It's been really brilliant hearing from you. And carry on the chat. I think even once the video stream has ended, you can still talk to each other there. So, keep the discussions flowing. So until next week, and until next time we meet, Mark and Claire, I'd like to send you my best wishes, and hope we can meet again very soon. Thank you for your participation.
Thank you. Thank you. Bye-bye.
Bye.
Thanks for joining in, everyone. See you next week.
Bye-bye.
Bye. Bye.